From Microbe TV, this is Infectious Disease Puscast, episode 45, recorded on January 3rd, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Did you have a good holiday, Daniel?
I did. It was a great holiday. I started off my conversation with David Renato, who helps with our recording, by regaling him of my victory in the New Year's regatta. I've been competing for about 10 years, and I don't always win, as in I have never won before. So this was a big year.
Congratulations.
For me. Thank you. And you, Sara, have you won any regattas lately?
No. I've been working a little bit, but I did have some time off to go see family briefly, so that was nice. Well, I guess we'll jump in. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. I will be starting us off with the viral section. And remember to listen to This Week in Virology, both our deep dive and we're still doing those clinical updates. Can you believe that? The article, Changes in Glomerular Filtration Rate After Switching from Tenofovir, I can't even say that. Sara, help me out. How do you say that? Disoproxil?
Yeah.
Okay.
I actually stumbled on saying the second portions of tenofovir the other day. Okay. So you're in good company.
So we've got good old tenofovir, disoproxil fumarate, to tenofovir alafenamide fumarate, or TAF, for HIV pre-exposure prophylaxis, published in Open Forum Infectious Disease. Here, the investigators conducted a retrospective cohort study using electronic health record data from Kaiser Permanente, Southern California. They identified individuals who switched from TDF, that's the old tenofovir, to TAF, the new, theoretically renally protective, between October 2019, May 2022, and used time-varying propensity score matching to identify controls who were on tenofovir. So we have our non-switchers as our controls. And they compared differences in the estimated glomerular filtration rate between the switchers and the non-switchers. Among 5,246 eligible individuals, they included 118 switchers, tenofovir to TAF, and 114 non-switchers. Switching to TAF was associated with a higher estimated GFR compared to staying on the tenofovir in 3 to 15 months post-switched, but the differences were not statistically significant. While most of the estimated changes showed this estimated GFR increase associated with switching, most were less than about 2 units. So not even sure it's even clinically significant. What I will say, and I, in a sense, I felt like when I read this article that they were asking the wrong question. Really, the concern is over time. The concern is an individual who might take too much. I'm just not sure this is a long enough period of follow-up. I actually was a little bit involved in some of the early TAF studies, and we had an individual who took their entire month of tenofovir, but they took it as TAF and had no negative impact on the GFR. So I'm not sure that this study is going to dissuade me relative to the superiority and safety profile of TAF relative to good old Truvada.
I can't believe I didn't have a viral article this section.
There must be no viruses. It's all like, I don't know, I've been working in the hospital lately. Have you seen any, Sara?
Just a couple. Well, I will move us into the bacterial section then. Be sure to listen to This Week in Microbiology. The first paper I pulled was from the New England Journal of Medicine, Doxycycline Prophylaxis to Prevent Sexually Transmitted Infections in Women. I can't remember which of us mentioned it, but we did talk about the DoxyPEP trial, which demonstrated doxycycline taken within 72 hours after condomless sex decreased gonorrhea, chlamydia, and early syphilis by 2/3 among MSM and transgender women who had bacterial STIs in the previous year. So this paper was a randomized open-label trial comparing doxypep with standard care among Kenyan women 18 to 30 years old who were receiving pre-exposure prophylaxis against HIV. The authors found that during the 12 months of follow-up, the incidence of STIs did not differ significantly between the two trial groups of cisgender women who were mostly young and in their 20s. There were 224 assigned to doxypep and 225 to standard care. A total of 109 STIs occurred, so that was about 50 or so in both of the groups, doxypep and standard of care. The use of doxypep was based on analysis of hair samples, and so when they looked at that, they found that use was low among 50 participants who were randomly selected, which is discordant with what the participants reported. So they were asked if they were taking their meds. So it certainly could be that a low uptake of doxypep explains why the results were different from the original doxypep trial that we talked about in the past. Some other limitations, we couldn't really draw conclusions on rectal pharyngeal STIs, and all the Neisseria gonorrhea isolates identified in the trial were resistant to tetracycline, and the incidence of syphilis overall was low. There was a very nice accompanying editorial from Dr. Marazzo, which nicely summarizes how we need to reconsider how to design intervention trials involving women of a reproductive age, and how these studies need to address not only the high incidence of a pathogen, but also the context of biological and behavioral characteristics that underlie individual susceptibility. So maybe not what people initially would have expected, but I think some caveats and limitations to think about.
It's a tough topic, I have to say, Sarah. I sort of wonder about, using doxycycline post-exposure. Even if it's successful, do we really have to worry about resistance, or is the one dose going to be something that just has an overall benefit? And particularly, you think about the population. This would be used in a population where maybe there's a high incidence of sexually transmitted infections, and so then you potentially have resistant organisms in that population. So I think this is something that there should be a lot of conversation around. So, maybe a little bit of a better study, because my takeaway here is if you don't take the doxycycline, how can it possibly work?
Mm-hmm.
All right. The article, Short Oral Antibiotic Therapy, it should be short course because they're not like using short antibiotics, but short oral antibiotic therapy for pediatric febrile urinary tract infections. A randomized trial was recently published in Pediatrics. So maybe it should be short course oral antibiotic therapy for short people because we're studying pediatrics, Sarah. What do you think? All right. I think this shorter course approach is only very slowly trickling down. Here we see the results of a multi-center investigator-initiated parallel group randomized controlled trial where they randomly assigned children aged 3 months to 5 years with non-complicated urinary tract infections to receive amoxicillin clavulanate orally in 3 divided doses for 5 or 10 days. The primary endpoint was the recurrence of a urinary tract infection within 30 days after the completion of therapy. Secondary endpoints were the difference in prevalence of clinical recovery, adverse drug-related events, and resistance to amoxicillin or to other antibiotics when a recurrent infection occurred. From May 2020 through September 2022, 175 children were assessed for eligibility and 142 underwent randomization. The recurrence rate within 30 days of the end of therapy was 2.8% in the short course group and 14.3% in the standard group. The difference between the two groups was 11.5%. The recurrence rate within 30 days from the end of therapy was only 1.4% in the short course group and 5.7% in the standard group. So They find that a 5-day course is non-inferior to a 10-day course of oral augmentin. Kind of seems to me that the short course group did significantly better.
Yeah, I still need to I hadn't read this one, but had marked it because I do feel like it's hard to have people commit to the shorter courses, particularly for whatever reason, UTIs and children. I think it's
It
been
is, it is
hard
interesting. And yeah,
to.
whenever we have like one of these like meetings and someone says like, "Oh, would you treat for 4, 6, or 8?" Like it just seems like very soon, "Oh, we treat to 8, let's just be on the conservative side." And there may be a problem, dare I say this, with too much antibiotics, as we saw here. We even saw this with antivirals. If you treat too long, you're not just treating the infection, but now you're really starting to disrupt the microbiome, which we kind of need. So yeah, I am hoping that data as compelling as this really helps push people to less can often be more.
Yeah. I pulled actually another paper, kind of follow up to something we talked about before, locally acquired melioidosis linked to environment, Mississippi 2020 to 2023. So I had previously talked about the report from MMWR, and then here is the follow up in the New England Journal of Medicine on 3 cases of non-travel related melioidosis caused by Burkholderia pseudomonas in the same Mississippi Gulf Coast county. So all of the patients were infected by the same Western Hemisphere strain that was discovered in 3 environmental samples collected on the property of one of the patients, indicating local acquisition from the region. These organisms had not been this organism, meaning the Burkholderia pseudomonas, has not been previously isolated from the environment in the continental U.S. And just to give a quick overview, the 3 patients. So the first one was a 39-year-old male, came in with fever, cough, hemoptysis, progressed to ARDS and multisystem organ failure. On hospital day 7, the organism was ID'd from a positive blood culture. The second patient was 62 years old, had a left upper lobe pneumonia and mediastinal lymphadenopathy and a sepsis-like picture, had positive blood cultures on hospital day 4. And then the third patient was a 64-year-old who came in with mid-back pain and a flu-like illness, found to have a spinal epidural abscess, and Burkholderia was ID'd in the blood and from the spinal abscess cultures. So the article talks about their investigation, such as where they collected their environmental samples. So I guess the samples that were positive were sort of like a puddle and some soil in the first patient's yard. And the genomic sequences in the strain, which they call GCS 2020 Gulf Coast strain 2020, are not a match for prior outbreaks, such as the aromatherapy spray one, which we also had talked about on Puscast at some point. So the exact mode of transmission and the exposure event is still not clear. There's some question that the authors posed about, maybe this was an inhalational exposure, given the second patient and the first patient both had cough and respiratory symptoms and sort of a pneumonia-like picture, but super interesting.
All right. The article evaluating the incidence of acute kidney injury and gentamicin synergy dosing for endocarditis, published in JAC Antimicrobial Resistance. I like this topic. The purpose of this analysis was to evaluate the incidence of acute kidney injury with gentamicin synergy dosing, comparing divided daily and once daily dosing strategies for infective endocarditis. These results are from a multi-center retrospective observational analysis at Brigham and Women's Hospital and Mass General up in Boston, Massachusetts. A total of 245 patients were evaluated for inclusion, of whom 147 patients met the inclusion criteria. Of those included, 101 patients were in the divided daily dosing group. I guess we know what's going on up there. And 46 patients were in the once daily dosing group. Groups were split into patients who received gentamicin divided daily dosing and once daily 3 milligrams per kilogram dosing for gram-positive infectious endocarditis. The primary outcome was the incidence of AKI defined by the rifle criteria: risk, injury, failure, loss, end-stage renal disease. A multivariable logistic regression analysis was performed. Notable secondary outcomes included hospital length of stay, need for gentamicin dose adjustments. The incidence of AKI was significantly higher in the divided daily group compared with once daily group, significantly 52.5% versus 13%. The divided dosing group had significantly longer median hospital length of stay, 19 days versus 13.5, and a greater number of patients who required dose adjustments, 76.2% versus 21.7%. But then they make a thoughtful comment in the conclusion. So obviously, this is great. Obviously, no one would ever divide up their dosing, but they say further studies are warranted to assess if there is a difference in efficacy between gentamicin synergy dosing strategies and in gentamicin compared with no gentamicin regimens for infectious endocarditis.
Yes, that's what we really need. Do you need gent at all?
It doesn't even work. It may be safer,
just use
but
it once a day. Yeah.
And do we even need it?
Yeah. Well, I also have another cardiac theme paper. This one's from OFID, Incidence of Lyme Carditis and Lyme Carditis as a Cause of Pacemaker Implantation, a nationwide registry-based case control study. This was as the title says, case control study from a Swedish national registry that found that 102 of a little over 81,000 patients with AV block were diagnosed with Lyme Virology. Out of the 25,000 or so patients who received a pacemaker, 31 were diagnosed with Lyme, and the yearly incidence of Lyme carditis as a cause of pacemaker implantation was 0.033 per 100,000 adults and year. The estimated risk for patients with Lyme carditis to receive a permanent pacemaker was 59%. The data available don't tell us whether the pacers were placed before we knew that they had Lyme carditis, or whether the responsible physician was unaware of the prognosis of AV block after treating with antibiotics. But regardless of the reasons, this is a huge percentage of pacemaker implantations that warrants awareness. Obviously, this was a small number of the total pacemaker implantation, but the paper, the authors comment that this is perhaps more generalizable to other European countries than the US, particularly given the genospecies of Borrelia. But I thought that was pretty impressive and a much higher number than I would have expected. So hopefully it helps with providing some education in this setting.
I worry, Sarah, because the cardiologists aren't listening to the ID Puscast. And so, as Borrelia spreads, right, as the ticks spread with that global warming that David Renata and I were discussing, we're going to start seeing this AV block in areas where the cardiologists are just not as familiar with Lyme as they might be here in the Northeast. And they're just, we got block. Here it is. They'll look at those squiggly lines I like to look at. They'll put in this pacemaker. And only after the fact might it become apparent that a short course of antibiotics might have corrected that.
Yeah. Well, I think I pulled our last bacterial paper. This one's from Clinical Microbiology and Infection. Pseudomonas aeruginosa, antimicrobial susceptibility profiles, resistance mechanisms, and international clonal lineages. Update from SGARS, SMID, ISARPE. I'll tell everyone what those stand for. This is a comprehensive update on Pseudomonas resistance mechanisms, particularly for XDR, DTR, international high-risk epidemic lineages, and how available beta-lactams and beta-lactamase inhibitors may impact resistance mechanisms. So the group SGAR, so it's a European Study Group for Antimicrobial Resistance Surveillance, which is part of ESCMID, which most people probably know, the European Society of Clinical Microbiology and ID. And then the initiative, I don't know if they abbreviate, ASARPAE, improving surveillance of antibiotic-resistant Pseudomonas in Europe. So there's a ton of information in the article, but it's distilled very nicely into Table 1 in particular, which takes categories of anti-pseudomonal agents and notes about the main resistance mechanisms. And then Figure 1 shows susceptibility profiles based on the relevant resistance mechanisms, such as ESBL and so on. So this is that classic green, yellow, red light chart that everyone has a copy of somewhere on their phone or their computer. So this is a new sort of updated one that's focused on Pseudomonas. So I highly recommend that you save this, because I think this will be a great reference. And I figured one take home or pearl, since there was so much information that we can't really talk about, is that the most frequent mutation-driven resistance mechanism for classic anti-pseudomonal penicillins and cephalosporins is the overproduction of chromosomal cephalosporinase AMP-C. So obviously a ton more covered in the paper. I encourage you to check it out and save yourself a new green, yellow, red traffic light table.
Great table.
Yeah.
All right, fungal. I should mention on Microbial Matters, there was just an interview with Arturo Casadevall talking all about the fungi and body temperature. So as I was saying before the show, when you cuddle up against someone who's warm, perhaps one of the reasons why their entire body is not as cold as their feet is thanks to the environmental evolutionary pressures of fungi. But let us start with the article defining optimal doses of liposomal amphotericin B against Candida auris. Data from an in vitro pharmacokinetic pharmacodynamic model recently published in JID. It turns out that C. auris isolates exhibit elevated amphotericin B MICs. They validated an in vitro model and report that the probability of target attainment was greater than 95% with 3 milligrams per kilogram for wild-type C. albicans isolates with MICs less than 2 milligrams per liter, and C. auris isolates with MICs less than 1 milligram per liter, where 5 milligrams per kilogram liposomal amphotericin is needed for C. auris isolates with MICs of 2 milligrams per liter or higher. We also have a Cryptococcus paper in Open Forum Infectious Disease. Sara, take it away.
Yeah. So Cryptococcus neoformans infections differ among HIV seropositive and HIV seronegative individuals, results from a nationwide surveillance program in France. This found that among 1,107 Cryptococcus cases from a French surveillance network, so this was 2005 to 2020, the proportion of HIV seronegative individuals surpassed HIV seropositive individuals as the main underlying risk group, which I think many of us have sort of experienced in training or practice. The authors observed differences in a couple things. So patient characteristics. So for example, patients living with HIV in the study were younger, more likely to be male. There were differences in their disease presentation. So cryptococcal meningitis and fungemia accounted for a smaller proportion of the patients that were HIV seronegative, so 89% versus 64%. And those other cases, isolated infections such as pulmonary disease, are more frequent. There was a difference in the cryptococcal antigen results. HIV seropositive individuals are more likely to have positive serum cryptococcal antigens at baseline. 12.5% of HIV seronegative patients with cryptococcal meningitis or fungemia had a negative serum CRAG compared to 2.8% for those living with HIV. And then kind of the other big take home was that crypto was associated with the higher mortality in the HIV negative individuals. So I think that this is meant to be a good reminder that HIV-associated cryptococcal meningitis, sort of the studies and changes, can't always be directly extrapolated to non-HIV immunocompromised host. But I think that being said, lumping together all of the different immunocompromising conditions is also not the ideal solution because there's a ton of heterogeneous risk factors. But still, I think a nice insight into how what we're seeing from a Cryptococcus standpoint has evolved over time, as hopefully, patients who are living with HIV are getting taken care of, but also we're seeing all these other patients who have transplants or are on other sort of novel immunosuppressive agents.
Yeah, really interesting how 2010, it's sort of the line crosses, right? And the HIV seronegative becomes the more common. And then I think this is, you got to keep learning, right? This in the HIV seronegative folks, 12.5% had a negative, serum cryptococcal antigen. So we've sort of had said, 97% sensitivity in HIV, but important to know the differences.
Yeah. I also really like their visual abstract. I only sometimes comment on the visuals, but I like their visual abstract.
Yeah, actually, that's nice. Yeah, they've got the 97.3, the 86%, 14%. So yeah, not as sensitive, that serum crypt antigen.
Yeah.
All right, Candida auris again. The article, Candida auris, a systematic review of a global emerging fungal pathogen in Africa, recently published in Open Forum Infectious Disease. The authors included 19 studies involving at least 2,529 cases from 6 African countries, with most, actually 94% were from South Africa. So it's almost a South African study and what's going on elsewhere. Among 527 isolates, 91.3% were resistant to fluconazole, 20.5% resistant to amphotericin, and 1.7% to micafungin. 90 of the 211, so 42.7% of the patients with clinical outcomes died. C. auris is associated with high mortality and antifungal resistance. Yet I'm going to agree with this. This critical pathogen remains underreported in Africa.
You had a little bit of a theme in your fungal article selection today.
Yes.
Well, I'll close us out with a paper from PLOS Pathogens. This is a Pearls on new anti-cancer therapeutics impact fungal pathobiology, infection dynamics, and outcome. As we all know, opportunistic fungal infections continue to emerge even in these supposed targeted therapies as we're trying to understand them. This paper has a really nice summary of fungal infection associations with select anti-cancer therapies. So that's in Table 1, along with some references. One example, just to sort of pull from the paper, is how the BTK inhibitor ibrutinib, which has been a major breakthrough for CLL and some other B-cell malignancies, has been reported to lead to fungal infections such as aspergillosis, Cryptococcus PJP, and a couple other more atypical infections. So that's sort of the first half of the paper. And then the second portion of the paper discusses whether we might use cancer therapeutics to fight fungal infection. So can we do drug repurposing, summarize a couple of things in Table 2 and mention other kind of related efforts like immunotherapy. And I think what is nice is their big take-home point is that these infections are learning opportunities, of course, to know what infection is associated with what anti-cancer agent. But beyond that, it also gives us some better understanding and insight into fungal immunity. So I thought that was a nice way to talk about this. It's actually a fairly quick read with some really nice tables. So people can read and check that one out too.
All right, we've got a few parasitic papers. Be sure to listen to This Week in Parasitism. On December 21st, 2023, WHO pre-qualifies a second malaria vaccine, a significant milestone in prevention of the disease. So WHO has added the R21/Matrix M malaria vaccine to its list of pre-qualified vaccines. In October 2023, WHO recommended its use for the prevention of malaria in children. It's for 5 and under, following the advice of the WHO Strategic Advisory Group of Experts, SAGE, I like that acronym, on immunization, and the Malaria Policy Advisory Group. The pre-qualification means larger access to vaccines as a key tool to prevent malaria in children, with it being a prerequisite for vaccine procurement by UNICEF and funding support for deployment by Gavi, the Vaccine Alliance. And sticking with that, the article seasonal vaccination with RTS, S/AS01 sub E vaccine. That was the first of these two, with or without seasonal malaria chemo prevention in children up to the age of 5 years in Burkina Faso and Mali. A double-blind, randomized, controlled phase 3 trial was published in the Lancet Infectious Diseases. So this is this concept of coupling vaccination with having children on malaria chemo prevention during the season when we're seeing the malaria. So these results are from a double-blind, individually randomized, controlled, non-inferiority and superiority phase 3 trial done at 2 sites in Burkina Faso. Children who had been enrolled in the initial 3-year trial when aged 5 to 17 months were initially randomly assigned individual to receive SMC, so that's seasonal malaria chemo prevention, with Fansidar, so that's sulfadoxine pyrimethamine, and Imodiaquin. I actually put in a little how to pronounce that for myself, Sarah, plus control vaccines. And then RTS plus placebo, SMC or SMC plus the vaccine. They continued to receive the same interventions until the age of 5. The primary trial endpoint was the incidence of clinical malaria over the 5-year trial period in both the modified intent to treat and per protocol populations. 6,861 children originally recruited. 94% of the children who completed the initial 3-year follow-up were re-enrolled in this extension study. Over 5 years, the incidence of clinical malaria per 1,000 person years at risk was 313 in the SMC alone, so just getting the chemo prevention, 320 in the vaccine group, and 133 when you did both chemo prevention and vaccine. Hospital admissions for WHO-defined severe malaria were reduced by 66.8%, for malarial anemia by 65.9%, for blood transfusion by 68.1%, for all-cause deaths by 44.5%. For deaths excluding external causes or surgery, really basically putting everything together. No safety signals were detected, and the SMC, so the chemo prevention and vaccine combined, really was the outstander.
Yeah. And then I pulled something from the Lancet ID, Guidelines for the Management of Toxoplasma gondii Infection and Disease in Patients with Hematologic Malignancies and After Hematopoietic Stem Cell Transplantation. Guidelines from the 9th European Conference on Infections and Leukemia 2022. So I just pulled a couple of their recommendations. The biggest of which they're proposing weekly blood quantitative toxo-PCRs in allogeneic stem cell transplant recipients who are seropositive for toxo pre-transplant, and the use of at least 6 months of Bactrim trimethoprim sulfa prophylaxis. But of course, this could be extended based on their immunosuppression regimen or severe CD4 lymphopenia. They recommend starting preemptive treatment if there is a positive toxo-PCR test, with the plan to continue until a minimum of 2 negative PCRs if the initial repeat is positive, or at least 6 weeks for disease, versus clinical judgment if you recheck that second PCR and it's negative. The authors base this blood PCR screening recommendations following transplant on a mix of 6 prospective and 5 retrospective studies. The mean incidence of infection in recipient positive patients was 9.6%. The overall incidence of disease in all patients was 1.4%. And most of these studies were done in Europe. I don't have a sense of if many people in the US are routinely doing this where they're screening for toxo, or if this is done in centers in Europe. So I'd love to hear sort of what people's practice patterns are. But I suspect this might be more intensive monitoring than some centers might already be doing. All right. And then I think we have a couple miscellaneous. I pulled a review article from the New England Journal on eye infections. There's a lot of great images. I'll point you specifically to figure 1, which has this really great detailed explanation of eye anatomy and a review. So remember that the eye has what they call 3 coats, the sclera, cornea, uvea, and retina. And then there's the 2 humors, aqueous and vitreous. And then the lens divides the eye into the anterior and posterior segments. The anterior segment is further divided by the iris into the anterior chamber and the posterior chamber. And so microbes that reach the eye through the bloodstream often see the uvea first because that's very vascular. And then I think another good learning point to pull out is that the retina is really part of the central nervous system and has a blood-eye barrier similar to the way we think about the blood-brain barrier. So that does impact antibiotic penetration. So the article covers infectious conjunctivitis, 80% of which are viral in adults, and then you can sort of flip that in pediatrics where the majority are bacterial and less are viral. There's a section on infectious keratitis or corneal infections, major risk factors that many of you may know, contact lens, eye trauma, and then underlying corneal disease or ocular surface disease. And then endophthalmitis section talking about exogenous versus endogenous. Key to treatment here is injection of intravitreal antibiotics, in some cases, vitrectomy. And then they do recommend systemic antibiotics for all cases of endogenous endophthalmitis, and then adjunctive antibiotics in some exogenous cases. So prophylactic IV vanc and ceftazidime for 48 hours after penetrating eye trauma, which has been shown to reduce the incidence of endophthalmitis. And then lastly, there's a couple small sections on infectious uveitis. So the uvea is your iris, ciliary body, and choroid. So they focused on ocular toxo, acute retinal necrosis, which should make you think VZV, HSV, syphilis, and TB.
I love the pictures.
Yeah, right, the diagram of the eye is so good.
The article, Clinical Impact of Multiplex Molecular Diagnostic Testing in Children with Acute Gastroenteritis Presenting to an Emergency Department, a multi-center prospective study recently published in CID. These are results of a prospective, multi-center, stepped wedge trial to determine the impact of multiplex molecular testing at 5 academic children's hospitals on children presenting to the emergency department with acute gastroenteritis. Potential pathogens were identified by clinician order tests in only 3.3% in the pre-intervention period, compared with 74% with this wonderful intervention. Clinically relevant pathogens were detected in 2.1% and 15% respectively. In the multivariate model, the intervention was associated with a 21% reduction in the odds of any return visit. And adjusting for potential co-founders, appropriate treatment was prescribed in 11.3%, compared with 19.6% during the intervention period. Viral pathogens were detected in 36%. We also saw enteropathogenic E. coli, norovirus, C. diff, Shigella, enteroinvasive E. coli. Those were the most common detected pathogens. I have to say, I had a personal experience today where we had this individual come in, basically septic, right? Bandemia, diarrhea. You know what it was? It was norovirus.
Oh,
and I don't think I would have normally thought of that as a norovirus presentation until, the introduction of this GI PCR testing. But all right.
I have to I do think I've publicly discussed how sometimes I don't like that test, but I
think I was thinking of that, Sarah.
If someone truly has acute diarrhea, I actually thought this was a really nice study and how sometimes it really does help to know what the pathogen is. So I have to acknowledge what I had said before.
Maybe 30 decades of not knowing what caused diarrhea and now actually getting an answer has really,
It is. It's satisfying in the right setting.
It's satisfying. I have a diagnosis.
Yeah. And then I have to give a mention to the BMJ Christmas specials, as I always love looking for these. So in BMJ Bug in a Mug, our hospital coffee machines transmitting pathogens. So I'll open with a quote. While the microbiome of coffee machines in general has already been described, their potential as a source of nosocomial pathogens has not been explored until now.
I like the dramatic. Yeah. I'm hooked. Keep reading.
The author swabbed 25 coffee makers, which I enjoy that they wrote with their owner's consent. And there is a delightful photo of the sites that they swabbed in the machine with an appropriately placed Santa in the back of the picture. The majority of the cultured species were commensals or atypical pathogens, but hospital-based machines did have heavier colonization than home machines. And so I figured it'd be best to just read their lovely quote. Hug in a mug. To our great relief, despite their potential for pathogen origins and nosocomial outbreaks, a general ban on coffee makers doesn't seem necessary. And then later, our thoughts now turn to tea-drinking nations. Are teapots, kettles, and hot water spouts similar breeding grounds for bacteria? Are the high temperatures in the pots sufficient to kill all potential pathogens? And what about the handles? So I have to say that I would consider getting a selected BMJ Christmas article as like peak performance. So I guess I have to start thinking of clever ideas to propose.
I like this. Yeah, we at one of the hospitals have one of those coffee machines, and it's been broken for weeks, right? It's not getting fixed. So there's some tiny little coffee thing that they give us as the substitute. And so finally yesterday, I was like, I have an idea. I'm going to explain why this is costing the hospital a fortune. So I explained that in our collective uncaffeinated state, we were not as efficient. And a single day delay in a hospital discharge was much more costly than sending someone to fix our coffee maker. And lo and behold, coincidentally, today, the coffee maker was fixed. I'm not saying there's any causation there, right? We'll have to do a study.
Yeah.
All right.
Yeah.
Let me suggest a fun read. The article, Put the Fluoroquinolone Down and No One Gets Hurt, published in CID. It's a fun article written by the Stewie pharmacist, Emily L. Heil, that captures how antimicrobial stewardship is so often done poorly. It's a brilliant piece, and let me just share a few parts. Emily writes, when I chose a career in infectious diseases pharmacy, I did not foresee spending my days giving unsolicited advice. I naively thought that everyone in healthcare shared the same level of concern that I did regarding the bleak outlook of antimicrobial resistance, and that the concept of antimicrobial stewardship would be a team sport. It did not take me long to figure out, while the average physician is in fact very concerned about antimicrobial resistance, the pull of the individual patient in front of them is much stronger than this elusive, seemingly far-off post-antibiotic apocalypse. She continues later on with, I believe that stewardship desperately needs a culture change. An overhaul on the way antimicrobial stewardship is perceived is essential if we want to have a sustainable, engaged, and fulfilled stewardship workforce. Maybe it starts with something as simple as semantics. Antibiotics aren't restricted, but protected. The official dictionary definition of stewardship is the careful and responsible management of something entrusted to one's care.
I love it. Protected antibiotics.
Yeah, it's not restricted, it's protected.
Yeah.
Because it's so precious.
That's an excellent way to end this episode. So that's the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts or microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions. Keep sending them to puscast@microbe.tv. And if you like what we do, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.